So our options for treating astigmatism depend very much on whether we're dealing with one of our laser eye surgery patients or a lens surgery patient, cataract surgery patient. When we're dealing with laser eye surgery, whether it's LASIK or SMILE, incorporating the patient's astigmatism that they have in their spectacle correction into that treatment profile is integral. It's a key part of getting that great outcome for the patient. We have to address their astigmatism. But it's very, very simple. It's just measuring their spectacle prescription and putting it into the treatment profile. So that's always part of our LASIK and our SMILE treatments, and we're looking separately all the time at our outcomes for astigmatism treatment and refining that nomogram to get it as accurate as we possibly can. When we're dealing with our lens surgery patients, it's quite a different approach. Often there is some relevance in knowing what the patient's astigmatism was before surgery, but we're going to change things completely for them with the removal of that lens. What's most relevant to us is the corneal astigmatism. So this is the shape of the front lens, the cornea, the window at the front of the eye. And their astigmatism is typically a result of that cornea being rugby ball shaped. It's steeper in one direction than the other. And so what we do is take really accurate measurements, customize software, and calculate a bespoke lens for that patient's eye. So that the lens we implant not only has plus minus power to bring that focus on the back of the eye, but also has differential power in two different directions. So the lens we put in has astigmatism to balance the astigmatism in the cornea. And this is really key to getting a great outcome for patients, whether they're having cataract surgery or lens surgery as a refractive procedure. So these are patients who are having purely refractive lens exchange. They may not have much in the way of cataract. Their main motivation is in obtaining maximum independence from spectacles. With those patients as a group in particular, eliminating the astigmatism is critical. If we're using a multifocal lens implant to share the light out, to create distance focus, intermediate and near, if that light is also being smeared by astigmatism, we're going to degrade the quality of the optics. We're not going to get the performance we want. We're going to get magnified glare and halo effects at night time. And so incorporating that astigmatic correction is really key. One of the little traps that's out there for cataract surgeons when they're running busy cataract practices is missing the fact that their patients have corneal astigmatism but may not have astigmatism in their spectacles. Now this isn't a common situation, but around about 1 in 50 to 1 in 100 patients, we measure their spectacles beforehand and there's no astigmatism. So these patients are not used to having astigmatism in their correction or in their vision. But when you measure their cornea, the window at the front of the eye, the lens that we're going to leave behind, we find that they do have some significant corneal astigmatism. And what this means is that for that patient, it just so happens that nature created balanced astigmatism. The crystalline lens inside their eye just happens to have the right amount of astigmatism opposite to the astigmatism in the cornea. But if you then simply take that lens away and put in a round, ordinary cataract lens, you are suddenly going to give that patient new astigmatism that they haven't experienced before, they're not used to. It's going to degrade the quality of their vision in a way that they really don't like. And so just being aware of that, taking those careful measurements and ensuring that you do restore that balanced astigmatism for those patients as part of your cataract surgery is really key to getting a great outcome for them.